I'm Lin Shu. I woke up with a medical system. It shows disease tags above heads.
What's this?
Only on patients.
Is this the cause?
You drink?
I do.
Smoke?
I smoke.
Stay up late?
All night.
Every night.
Others step out.
Nah, doc.
They are family. Just tell me.
Nothing to hide.
Kidney deficiency.
Posting it now.
Young master once busted.
Bullshit! You quack. I'm perfectly fine.
Let's go. Switch hospitals.
Don't worry. I can cure it. Just cooperate.
Quick!
Get up. Get up.
Stick to this.
One daily.
Dr. Lin, fully booked. Bed 3, ops, new headache case. Dear, browse with him. Go give a hand.
Got it. On my way.
Just monitor. Probably a migraine.
Again. Temps 37.2 below threshold.
Not even a fever.
Doc just checked. Why recheck?
Double checking. Checks out. What's the tag say? Auntie, what's her normal temp?
She's always been cold. Checked her last year. Just 35 something. Thought the meter broke.
Baseline 35.5 up to 37.2. That's like spiking to 38.2. Diagnosis is right. Headache, vomiting, fever, plus neck stiffness. Meningitis. Dr. Zhao, bed 3's baseline's mid-30s. 37.2's a high fever for him. Headache with fever? Rule out meningitis.
Early tests can be negative. You think I missed it?
Let's recheck meningeal signs. Or do a spinal tap.
How long you been here?
ER. Male. 51. Headache, vomiting. 3 days. Temps 37.2. Baseline's just over 35. Meningitis is highly likely. Request a consult.
Your attending already saw him.
Attending called it a migraine, but I'm ruling out meningitis.
Fine. I'll go check on him.
Stiff neck. Brzezinski's.
Kernick's.
Both sides positive.
40 minutes ago, Zhao's test was negative. Now it's positive.
Who told you to call?
I called.
Wheel him to procedure. Get the spinal tap.
Confirmed bacterial meningitis. Dr. Song, start empiric antibiotics.
You made the right call.
Doctor, thanks.
Internal med basics. What's this?
Patient's meningitis falls under internal med. You mean every patient I see, med or surgical, ground skill shards.
You bypassed me for neuro.
But you were right. He's alive.
But you're a resident. Can't bypass the attending. Filing this marks your record. I'll bury it this time. Tell them I approved. But there's a penalty. No patients for 3 days. Hands off patients. Copy the consult rules. Medicine's one thing. Rules are another. Both are mandatory. Go on.
Clipped by a turning car. I took a spill, just checking the scrape.
Where's the injury? Did you call the cops?
Left elbow scraped, left ribs bruised. Nothing serious. Didn't call cops. Gotta deliver orders. Can we hurry?
No, urgent case. Go wait over there.
Thanks. Still bleeding. Fell off my e-bike. Scraped on the left. Bruised my ribs.
Just superficial. I've got it. Off duty for 3 days. No patient contact.
Go home and rest. Don't lift heavy things.
If it aches,
Just take one.
3 times daily max.
All right.
I'm heading out.
I know. Almost done.
10 minutes.
Don't dock my pay.
Not asking for leave.
I actually fail.
Fine. I log on when I arrive.
Yeah.
Mom, no big deal. Just a scratch. Don't come for cash. I'll send it next payday.
All right.
I'll pick up Duo tonight. Tell her dad's okay.
Gait steady.
No limp, not holding his stomach. Complexion's fine. Breathing's even. Elbow gauze is clean. Scratch is still bleeding.
Still bleeding.
Why is there no surface bleeding?
It's internal.
Inside. Left ribs hit the spleen. Subcapsular hematoma. Blood's pooling under the capsule.
It'll burst.
Blood floods the abdomen. Hemorrhagic shock. Delayed splenic rupture. Internal bleeding. Blood irritates the diaphragm.
Left shoulder aches.
Sorry. It's fine. Shoulder's never been hurt. Light touch, and he hissed. Internal bleeding.
Positive.
Mr. Zhao. Urgent.
Hold on. What's up?
Patient just came in. 23. Courier crashed an e-bike. Hit left ribs. Dr. Chen did the stitches.
Prescribed painkillers was gonna let him go.
Suspect a splenic bleed. Hit right under left ribs. That's where the spleen is. Signs of internal bleeding.
Left shoulder's hurting. No external wounds.
Plus, rapid breathing.
Sorry, had an emergency today. Come back next time. I'll squeeze you in next time.
Yay.
Where'd he go?
Picking up meds. What about the courier? 23. Black t-shirt. Left hand's bandaged.
Oh, him. Grab meds and left.
Back off!
You can't leave. Step aside.
You could be bleeding inside.
I just saw a doctor.
He said I'm fine.
I know.
But I'm running tests.
I know my own body. It doesn't hurt at all. Just a scratch. Trying to squeeze more cash?
I'm the ER attending.
Dr. Zhao.
Left ribs took a hit.
Just a bump. Nothing serious.
Come back for a scan. 5 minutes. If it's clear,
I'll see you out.
5 minutes.
5 minutes.
Fine, Dr. Zhao. If tests are clear, I'll report you both.
Your spleen's torn. It's bleeding. Not much right now, but it could worsen. You need surgery. It's bleeding out. You hit your left ribs. Your spleen's damaged. Blood's pooling inside. It's contained now, but it won't hold. It's already leaking.
You need an operation. Roughly how much?
Got insurance.
Yeah. Rural. Out of province.
It'll cover some. The exact cost paid after admission. You need admission now.
I can't afford it.
If you wait now, bleeding will spike. When the capsule bursts, you'll go into shock. It's not about money. It's life or death.
Gotta pick up my daughter.
I'll call your family. Give me the number. Get the surgeons here.
Damn it.
Take her to the OR. Prep for surgery. Tomorrow. Starting tomorrow, you can take cases now. Next time, evidence or not, come see me first.
Basic surgery. My guess was right. Fragments increase per patient. Don't know what happens if I collect them. Courier's heart rate when he came in? 98. I checked. I saw 98. Figured it was just pain. Didn't think of anything else. Doctor, chest tightness for 2 days. Feels like a weight when I move.
Do you smoke? Blood pressure?
Blood sugar?
Oh, over 30 years, a pack a day. High blood pressure. Meds are irregular.
My dad died of a heart attack. Doctor, is it serious? Got a chess match this afternoon.
Let's check the ECG first. ST depression. Most obvious in these four.
Roughly 0.5 millimeter.
Right in the gray area.
ST segments a bit low.
Not very specific. Let's check the enzymes.
Last 2 times.
Points to fever and internal bleeding.
What's different now?
ST segments depressed. This is the worst. Roughly 0.5 millimeter. Right in the gray area.
Could trigger a heart attack.
I need another ECG. Tests are normal. Repeat ECG every 30 minutes.
That long.
Why run it twice? To catch any changes.
Just a little tight. Rest at home for 2 days. My wife made me come. Since you're here,
Then we'll find out.
dropped from 0.5 to 1.5 in an hour.
Dynamic ST depression. Unstable angina.
Master Wu.
ECG worsened in an hour. It's unstable angina. Act now or face a heart attack.
Heart attack.
Choose 300 milligrams of aspirin.
Push heparin sodium 5. Run nitro on the right IV.
Admit to monitor and call consult.
Doctor, don't tell my wife. Her heart's bad.
Admit him.
I'll handle her. Don't call anyone.
Old guy with chest pain is in. Initial ECG and enzymes were fine. Why the recheck? Too many risk factors.
30 years of smoking. Family history of hypertension. Plus 2 days of chest tightness.
Single ECGs inconclusive. Gotta see the trend.
Good point. ST changes weren't diagnostic, so I skipped the follow-up. Let's go. Dr. Zhao, you're presenting this case.
Adding a case discussion. Lin Shu.
Male, 62,
2 days chest tightness.
30 years smoking history,
Hypertension.
father died of MI. Initial ECG lead way for video ST depression, middle ST limiter, enzymes normal. Given the high risk profile, recheck in an hour. Risk depression deepened to 1.5 millimeters. Diagnosis, unstable angina, admitted to cardiology.
Enzymes still normal. Guidelines use this for low risk strat. With normal lab results, you still order a repeat ECG, driven by cumulative risk factors, or the initial ECG's ST changes.
Alone, they're not high risk. Together, they're serious. We gotta rule it out.
With normal cardiac enzymes, it's aggressive procedurally. Your call's right. Holter monitoring's value is often missed.
Good job.
Today's been quiet.
Yeah, pretty quiet.
Shift's over. See you tomorrow.
Improvement. 2 cases sorted.
3 left. Surgeries 1 from the ER. Surgeries too few. Haven't eaten. Just had the cafeteria food. Admitted a tricky case. What's up? 10-year-old girl. Low-grade fever for a month. 3 hospitals, no diagnosis. Transferred here. Our team stumped. Prof, Lu's still unsure. We've run all the tests. Low-grade fever for a month. Get some rest.
You too.
Hi, is Zhou Han in?
Dr. Zhou's on runs. Hold on, he'll be done soon.
All right, thanks. The color's off. That pale green means more than one.
Could it be two conditions?
Just here to borrow a book. Heading to the office. Which report? Fever of unknown origin in kids. The girl on bed 3. Su Jinyan, 10 years old, right? Symptoms for a week. See for yourself. Ruled out most immune causes. ANI is negative. Complements normal. He said his left knee ached. No redness or swelling. X-rays clear too. Leaning toward growing pains. Definitely tricky. I return it after reading. Still reading papers after shift. Can't sleep. All I see is that feverish girl. Checking for missed causes. All immune markers are normal. Dr. Lu wants a room consult, but we lack evidence. My biggest fear is sits in the hall eating bread at noon. No tears, no fuss, just asks, any results yet? I just say still running tests. Don't know how much longer they can hold. Still hurting in the left knee. A bit after he moves around. X-rays clear. Suspected growth pains. Hemoglobin levels. Last test, 108. Was 1-2 at the other hospital. Why is an ER resident so invested? 3 hospitals came up empty. It's pretty rare. You just can't walk away from a puzzle. Anyway, where after residency? Enrolled in prep courses? Never thought about it. You're impossible. Never mind. Get some sleep. Not an infection. Black cultures are negative. WBC counts normal. So what's driving the fever? I think I know. Paul Su Jinyan CBC history. Sorted by time. Plit at 285. 313 cc hectare. Day 3, 346. Climbing again. Still under 350. But it keeps climbing. Hemoglobin's in 112. Drops again. Plate climbs. HGB keeps dropping. Chronic inflammatory thrombocytosis. Inflammatory anemia. Plus, CRP's high. Bleeding fast. Chronic inflammation active. No infection. Not typical autoimmune. So what's the culprit? When did you spot it? Couple days back. Wanna report to Prof. Lu with me? You're his primary doc. Data's right there. Who spotted it first doesn't matter. You should lead the report. Besides, I'm on rounds with Deer. Zhao tomorrow.
Doc, my stomach's hurting. Why check my heart?
Sometimes, heart issues can mimic stomach pain. We do this to keep you safe. Gotta rule it out first.
In his 40s, manual laborer, 1 pack a day. High cardiac risk. Not abdominal, then where? ECG rule out MI. Chest exams clear. Maybe the spine?
Point to the pain.
Like here? Mildly. Not the worst.
Ouch! Rebound tenderness. Stat abdominal CT. Bed 3, Ma. Wrong spot. He's pointing off belly. His appendix is misplaced. I overthought the system. Chasing rare diseases. Skipped basic palpation. Zhao cracked it with basic. Brother Ma.
No worries. Appendicitis. Surgery fixes it. Pay can wait.
Stalled. Looks like Only my diagnosis counts.
What did Prof. Lu say
About her case, she reviewed the blood work, says everything's normal.
Just variations. Hospitalized diet. Repeated draws skew results.
So her call? Watch and wait. Recheck next week. If it worsens, then change tactics. Watching's fine. But the family suffers a week. Is she right? Makes medical sense. But check one more marker.
Which one?
Serum ferritin. If it's chronic inflammation, it'll stay normal or high. But drops with iron deficiency. Opposite results. This pins down the cause. Excuse me, where's Dr. Zhou?
Dr. Lin, Dr. Zhou's with Director Lu on rounds. Haven't got back yet. You were here yesterday.
Came to return a book to him, but he was out, so I dropped by to see you.
Is that med textbook any good? Definitely not as good as mine.
What's it about?
A cat living on the roof sees everyone's secrets. Like the flower grandma who hates flowers. Wants a chat. The jogger isn't working out, but looking for a lost dog.
Being here almost 2 weeks, or being alone?
Not too bad. Got books to read. Nurses sometimes give lollipops. You're not our pediatrician.
How do you know? I'm not, actually. I'm in the ER.
Is the ER busy?
Pretty busy.
Since it's so busy. So, how'd you find time to drop by?
Just to return a book, but mostly to check in.
Check on what?
Just you. Dr. Zhou mentioned your case is complex, so I got curious.
Oh, Dr. Lin, are your glasses heavy?
What?
'Cause you keep pushing them up. Once at the door, once walking in, and again just now. Sweat making them slide?
You've got sharp eyes.
Nothing to do in here, so I just people watch. You are her mom? She's in the ER. Said she's here to return a book. They know each other.
Hi, I'm Dr. Lin. She's Dr. Zhou's neighbor.
Oh, hi, Dr. Lin. My name's Fang.
I won't keep you then. I'll leave the book at Dr. Zhou's office. See you.
Sure. Take care.
Dr. Lin, get glasses with a strap next time. Wear them around your neck. They won't slide down anymore.
Right. The system flagged multiple clues. Plus that kid's abnormal left nail curve. Didn't just grow out of nowhere.
Bed 3.
六关 ceftriaxone tests clear. Start 2 IV drips.
Add ibuprofen for the fever. Once temps under 38, discharge him.
Narrowing? What's narrowing?
Water.
Listen, open up slow. Vida, let me see. Sign of severe airway blockage. Look again. Bro, push through it. Vida. Light up. Look deep left.
Hook up the monitor.
Check O2 sat. Sat at 96. Still stable.
Push 10 Benjamin Dexstat.
Stop the swelling.
Page ENT now. Bed 3 abscess blocking airway. Bring the attending with the kit. Prep track kit at bedside. Track him if he stops.
Feel better. Thanks, Doc. Just the final piece. I checked his throat. I saw it clearly. Classic purulent tonsillitis. Matches the textbook. Right. Just a 12-minute gap. It's way too common. We see 6 or 7 daily.
So I didn't check his neck. He walked in with a sore throat. I just assumed it was inflammation. I didn't even check his jaw opening.
Tonight, if you hadn't rushed over for a glance.
He died despite my diagnosis.
You were typing meters away. You didn't even touch him. What exactly did you see?
I stood by the bed 12 minutes and missed it.
How did you even notice? When you walked by and checked him, he swallowed and looked up, noticed a slight neck asymmetry.
Plus a muffled dull sound. Put together, that's not just inflammation. That's it.
Just like that. It was just an angle issue. Wrong angle, and I'd miss it too.
This whole thing.
I owe you big time.
Ferritin results are in. Ferritin, 235.
High. Hemoglobin, 102.
Dropped 4 PTs in a week. Platelets, 358.
Hits the normal max. Anemia's worsening.
What did Prof. Lu say?
Can't blame hospital stress this time.
Med Depart ER, Lu Ming. Su Jinian's not right.
Requesting joint room and hem rounds.
What's the verdict?
Riem says evidence is thin.
DNA 阴性, told to stay on watch. Hematology is not until Monday.
Any new symptoms lately? Day before, left eye dry, rubbed it several times.
Prof. Lu says dry AC.
Left knee still aches.
Checked his retinal vessels. Fundus is clear. Why check that?
Infection ruled out.
Autoimmune ruled out.
Rim stumped. Left eye dryness. Retinal vessels. Still unclear.
Let's wait for the hematology results.
Dr. Lin.
Fang.
He's barely eating.
Dr. Zhou fill you in on the consult.
He did. Still checking.
Fang, where do you eat lunch?
Just grabbing a bite on the bench.
The downstairs canteen's cheap. Families can queue for ribs too.
Canteen's too far, 20 minutes round trip. If he wakes up in pain, he'll get scared without me.
Stop worrying. Didn't push your glasses.
Maybe you didn't sweat.
Just passing by.
Oh.
His heart's racing. Refused to come for a week. Almost collapsed at work today. I had to drag him here.
It's nothing serious. Just a fast heartbeat. No big deal.
Can you describe the symptoms?
It's not racing. It's jumping around. Irregular beats.
Any discomfort lately?
No.
Lost any weight?
No. He's lost weight. He's on the second notch. Waistbands loose. Just loose pants. Appetite's normal. Actually, it's hungry at midnight.
How much per meal?
Gets worse at night. 1 bowl was enough. Now a bowl and a half. Run an ECG.
P waves are gone, replaced by F waves. RI intervals vary. Classic atrial fibrillation. Warm, damp palms. Palms slick with sweat.
Swallows hard.
Gejiao sign. Heart rate spiking. Metabolism's racing. Thyroid dumping hormones. Whipping the heart. Burning every organ.
Classic hyperthyroid AFib.
Doc, is it life-threatening?
It's a thyroid complication.
We can control it with meds. It's not fatal. Go to endocrinology.
Thanks, doctor. Thanks, doctor.
Breathing's restricted.
Classic early signs of Syndrome O.
Left lower lungs consolidated or has fluid. That explains it.
Gather 5 fragments each time. My medical skills level up.
I can tell on instinct alone.
Who's handling bed 4's oxygen patient?
It's Dr. Liu's.
Run it by Dr. Liu.
Rush a chest x-ray for bed 4.
Focus on the left lung base.
Everything's fine.
Started with chronic inflammation,
Then a fever,
left knee pain,
then anemia.
high platelets, then sudden weight loss. Left hand shows asymmetric clubbing.
Why just the left?
Only the left side points to a localized lesion.
What only cuts blood flow on the left?
Left subclavian artery off the aortic arch. If it inflames
and blocks.
10-year-old girl fainted and fell. Forehead trauma. Unconscious for 10 seconds, then recovered. Mom's always sleepy.
He needs the bathroom.
I said, help him up.
He insisted on walking. Fell on his 3rd step.
Eyes.
Exam, superficial abrasions. Not deep, no stitches. Pupils equal and round. Light reflex intact. Mild confusion.
95/60.
Too low. Normal systolic for a 10-year-old girl is 100. Low BP starves the brain. Stand up, BP drops below consciousness. They black out.
Why is the BP so low?
Clubbing. Irreversible chronic hypoxia.
Severe asymmetric distal ischemia. What disease cuts off one major artery? Hand me the cuff.
Gaps is huge.
Right arm, 95/60. Left arm, 68/35. Systolic gaps, 27.
Pulse is weak.
Pulse strength is normal.
BP's this off. Cuff too loose.
Recheck it. It's not the cuff.
68/35.
Clubbing points to a weak left pulse. Every inflammatory marker is left-sided. Not some undiagnosed primary issue. It's the vessel wall itself. The large vessels are quietly burning. Been burning for 3 full months.
Make a call.
Get Dr. Zhao here right away.
Now.
Now. Right arm BP, 95/60. Left arm, 68/35. BP difference, 27 mm Hg. Weak left radial pulse. Right's normal. Continuous bruit in left subclavian. Low fever for 3 months. High CRP and ferritin. Elevated ESR. Protein levels dropping. Platelets keep rising. ANA negative. Bone and marrow clear. Left hand clubbing. No. Migratory left knee pain. Severe weight loss. G-year-old girl. Arteritis. Set CT of aorta and branches. Now. Call radiology. Now. Tell them ER needs priority. Takayasu arteritis.
Rare in kids.
Seen this before? Inferred from books and exam.
Wait for results.
Aortic arch level. Left subclavian artery origin.
Call rheumatology for a stat consult. Write the order now. Attach the CTA results. Diagnosis: Takayasu arteritis.
Dr. Lin, what is this mystery disease?
It's an autoimmune vasculitis. The aorta wall is inflamed and thickened. This narrows the vessel. Severe ischemia in the left arm and brain, causing the fainting. The fever, anemia, weight loss, all from the body fighting the inflamed vessels. It drains the system.
Can it be treated?
Yes.
I'll help the pediatrician with his stuff, transferring to rheumatology. Thank you. You're the attending. You made the diagnosis. I've stood by his bed for 3 weeks, checking labs daily, but never tracked the trends. Never thought to check ferritin or measure bilateral blood pressure. You don't know him well, yet you see right through him.
Took a kid inpatient at the ER last night. 10-year-old girl. Recurrent fever for 3 months. Undiagnosed after 4 hospitals. Brought in after fainting. BP's uneven in both arms. Weak left radial pulse. Murmur under left collarbone. Aortic CTA done stat. Severe left subclavian stenosis. Thickened left carotid wall. Uneven thickening in the aorta. It's Takayasu arteritis. Moved to rheumatology. On steroids now. Initial assessment. Lin Shu handled it.
Solid work.
Not bad, kid.
You're here.
What'd you eat today?
Congee. Plus an egg. Just boiled. Yolk's kinda dry.
Ate half a bowl yesterday. Ate a full bowl today.
Nurse logged it.
New log.
Dr. Joe sent me. He said whales beat cats. Let me see the big ones.
Tests are trending down. CRP dropped from 12 to 7. Temps been 36.8 since yesterday. No fever for 2 days. Thanks, Dr. Lee.
No problem. Just doing my job. She's all clear. I'll head out.
Let me introduce you.
You must be Lin Shu.
Yeah. That's him. That's the one. The case 4 hospitals missed. He figured it out. Takayasu arteritis. 10-year-old girl. Hospitalized a month. Stumped everyone else. You know how he spotted it? He just checked her BP.
Noticed something off on the kid.
Both arms.
One high, one low. That's it. Simple as that. Others just missed it. 4 hospitals. No one checked both arms.
Pretty sharp.
That's just him. You tell him anything. He's quiet but sharp.
Takayasu arteritis. I've only read about it. It's just 1 page in the books.
So, just 1 page. He nailed it.
Dr. Lin, heard about the arteritis case. You had Zhou check ferritin to track the trend.
You prompted him too. We just talked it over. Thanks for the input.
Did you spot the clubbing first? Or the low BP?
The clubbing came first. Second time I checked, saw him drinking. Left index and middle fingers curved more. Gave me a lead. Checked his BP in both arms. That confirmed it.
All right. I'll add this to next month's training. I'll credit you as the organizer. Fundamentals matter. Next up is general surgery. Your internal med background's a plus. Just don't lean on it in surgery. Learn to use your hands first. Let's go.
Heard you're heading to Gen Surg?
Yeah.
Sounds good. You'll learn a different approach. When do you start?
Right away.
You did well here too. You'll be a great doctor.
This spot's tricky to cut.
You're the new intern, new on rotation.
Lin Shu.
Wei Mingchuan. I'm your preceptor. Follow me. Learn the ward layout.
Nurse Liv runs the station. Ask her about orders. Just follow me. Start with dressings tomorrow. Hold on building goals. Know the forceps spot. The OR's on floor 5. Shoe covers in the cabinet. Don't wear them inside out.
That's Dr. Guo. He's swamped. Ask when he's free. Head to the office.
You're on bed 12.
Bed 14. Not many. Just get familiar.
Bed 12's drain comes out today. Under 50 ml pale yellow. Pull it.
Get me when you pull it.
Oh, right. Heard about your arthritis case.
Spot on diagnosis.
But park it here for now. Surgery's about your hands. Haven't seen yours yet. We'll see when you pull it.
Got it.
Lin Shu reported today.
Pulled the drain today. Checked it this morning. Output's under 40. Color's normal.
Let Wei show you how. Don't touch yourself.
Your turn.
It's normal the first time. You'll shake more on the table. Easy, sir. Relax. Minimally invasive, 3 holes. Done in an hour. Pre-op's all set. Coagulations checked. Copy on the table at 9:30.
Let's go. Chief. Starting now. You divide the facial layer. Bone secured. Final 3 stitches.
Lin Shu, your turn.
Spacing's uneven. First and second are too off.
It's fine.
Suturing's a basic skill. Drill it 100 times. You'll get it.
How are you feeling?
Not bad. Hurts a bit when I breathe. I can handle it.
Bell sounds 3 to 4 min. Back to normal. Temps 36.5. Heart rate 78. BP stable. Abdomen soft. Incisions healing well. Rest up for now.
Dr. Lin, bed 14's anticoagulant. LMWH prevents clots post-lap. You didn't order it.
I'm not ordering it now.
Follow the checklist for orders. Don't rely on memory.
I catch it right in the ER, but he missed this life-saving step.
Even with copies, I missed meds. Here, use this.
Thanks.
Why check again?
Let me check again.
Hurts a bit.
Ow. Rebound tenderness. Post-lap surgery. Peritoneal signs far from the incision. Unknown irritant roaming the abdomen. Most likely hidden post-op bleeding. Dr. Wei's in trouble. Bed 14. Mild irritation lower right. Tenderness is positive. Rebound tenderness suspected. Nowhere near the cut.
What? Get to the ward. Run a CBC. Get an abdominal US. HB's down 8 points from pre-op. Scan shows little free fluid in the lower right. Minor oozing. Not much. Watch it for now. Start IV fluids. Recheck CBC in 4 hours. If it drops further, we'll act. Since the incision looks fine, why check the lower right?
I always scan every quadrant. Not just near the cut.
ER taught you that?
Yeah.
Good habit. Keep it.
If bed 14 shows bleeding, did you adjust the order?
Writing it now. Well, heard Guran grilled your sutures. Yeah, totally normal. Guran's called 2 mm. Stitches need to be within 2 mm. He's made fellows cry. Looking this good, no one dares to make a move. Think about it. Say you two kiss. What if he nitpicks your 2 mm angle?
But their technique's solid. My mentor said, honest feedback's a blessing. No feedback's the real scare.
Admit it. Talking to him.
He's just a total introvert.
Keep it up.
Dr. Lin. Thanks, Doc.
No problem. Take care.
No sounds.
Hello. I'm your doctor. Need a pre-admit physical. Any weight changes lately?
Lost a bit.
How much?
72 kilos 6 months back. Now, around 66.
6 kilos. Deep breath.
It hurts. Breathing steady. No guarding. Gallbladder tenderness, positive. Atypical.
What's wrong?
Nothing. Exam's normal.
We recheck before surgery. Get some rest.
Suspect gallbladder tenderness. Lost 6 kilos in 6 months. Heart, fixed node above left clavicle. That's a Verk node. Hallmarks of abdominal cancer spread. CT shows thickened gallbladder walls. If it's not inflammation, it's a tumor. If we operate for acute cholecystitis, minimally invasive won't clear it. Once opened, if it's gallbladder cancer.
Without prep, it's malpractice.
I need evidence. Contrast CT or lymph node biopsy.
Dr. Wei.
Here are bed 22's emission findings. Wanted to run them by you. Murphy's signs atypical. Palpating the GB point, patient inhales deeply. Breath held, no pause. Just a dull ache, constant, not sharp.
Murphy's sign isn't always textbook. Chronic cases just ache. Acute phases vary too.
Lost 6 kg in 6 months, from 72 down to 66. Patient and family confirmed.
Got it.
Poor appetite. Thought it was the GB.
Anything else?
Palpable left supraclavicular node. Roughly 1 cm. Hard. Fixed. Non-tender.
Let's go. I'll check him.
I'll examine him.
Order a contrast CT, abdomen and pelvis. Schedule it tomorrow. Pause bed 22 surgery.
Bed 20 surgery is off.
Why atypical gallbladder tenderness? Clear weight loss. Nodes on the left clavicle.
It's Virchow's node.
Right.
Gallbladder cancer. Stage T3, at least. Cirrhosis invaded. Nodes near duct and aorta.
Not cholecystitis. Never was.
I'll go find Director Han.
Contrast CT confirms it. Stage T3 minimum. Para-aortic nodes show multiple mets. Laparoscopy is off the table. Oncology needs a consult. PET-CT first. Check for distant mets. Who did the pre-op exam? Lin Shu.
Left supraclavicular node. Losing weight. Gallbladder tenderness is atypical. Based on the full picture.
He keeps this bed.
CT rules out simple cholecystitis. Suspect a mass.
PET-CT and unconsult are set.
Is it serious?
Need more tests to know. We'll move fast.
Mom, PET in 2 days. Oncology will draft a plan.
Doctor, does mass mean cancer?
Wait for final results. Rest assured, we walk fast.
Thanks.
Gotta collect 10 fragments. 2 small hypermetabolic foci near the gallbladder bed. Max diameter is about 1.2 centimeters. Multiple hypermetabolic nodes near the abdominal aorta. Distant metastasis. Metastasis to the liver and lymph nodes. Stage at least IVB. Surgery is off the table. Chemo's recommended. Gemcitabine and cisplatin. Check liver and kidney function first.
Transfer to oncology. Let oncology decide the plan. Go tell bed 22 about the transfer.
Dr. Lee, I'm moving upstairs.
The chemo plan.
Oncology'll explain it all.
Ring the bell if you need me.
Thanks for catching this. If you hadn't found it, we have operated for cholecystitis and missed the real issue. That would have been a disaster.
Get some rest.
Always asking for loans.
Called it right.
Andrew's having a good day. Hands are syncing up.
Just one piece left.
You know what we see most? Coughs. All coughs. Saw 12 this morning. 11 coughs. Once just for reports. Hear a cough. Check the lungs. Guy coughed twice beside me. Nearly grabbed my...
Then you fit respiratory well, specializing in coughs.
I'll pass. Also would have been easier. Snap. And it's fixed. Clean and precise. Not like respiratory. 2 weeks of coughing. Still going. So frustrating, right? How about you? How's surgery? Heard you caught another tough case.
Yeah. What is it? Gallbladder cancer. Damn. Admitted for cholecystitis. How'd you catch that?
I palpated him.
Another physical?
Are your hands CT scanners? Others feel him and find nothing. You touch him and find cancer. Where's the patient? How's he doing?
Transferred to oncology. Starting chemo. Oh.
Is that early detection?
Not really. It's already spread.
Damn. Forget it. Let's drop it. Let's eat.
Diagnosed with bronchitis. Switch antibiotics to fight infection.
Pull up past CBCs for trends. Track WBC and eosinophil shifts. Can't just focus on one point. You gotta see the trend. Eosinophils are climbing. Persistent dry cough. 2 antibiotic runs failed. Think it through. Still bronchitis? Run an IgE panel.
ER center female, age 43, acute abdominal pain. CT shows SMA swelling. Page surgery stat. She's rolling in.
Started hurting around 7 or 8 p.m.
Thought it was food poisoning, but it kept getting worse. Waited it out at home.
Dr. Wei, ER sent over an acute abdomen, 43-year-old female. CT shows mesenteric vessel issues with fluid. BP's a bit low, 90/60.
Start fluids to boost BP. Run a CBC.
Scan panel. Collect panel. Get a contrast CT.
Let me examine you. Just relax. Diffuse tenderness, rebound tenderness. Bowel sounds are weak, but they're still there. Doesn't look like necrosis or perforation. How long's the finger pain?
About 6 months. Morning stiffness. Thought it was rheumatism.
Turn your face here. Face the light. The red rash on your face. Does sun make it worse?
Frequent mouth ulcers. Hair loss too.
Gets worse in summer. They just keep coming back. Clumps out in the shower. Figured it was just stress and age.
Roll up his pant leg. Hold on a sec. WBCs are low. Platelets low too.
Not an infection.
No blood loss. Marrow suppression or autoimmune attack.
WBC at 2.8. Platelets at 89. Blood works abnormal.
If it were just mesenteric ischemia,
Just a stress response.
WBCs would be high. Order an abdominal CTA.
IV fluids first. Stabilize BP.
Dr. Wei found extra abdominal signs.
What?
Swollen finger joints, symmetric. Butterfly rash on the face. Worse in sun. Live dew on legs. 6-month joint pain. Chronic mouth sores. Bad hair loss. Plus low WBC and low platelets. Urine protein is 2+.
What do you suspect? What do you suspect?
It's systemic lupus. Could be lupus vasculitis. It's autoimmune. Autoimmune marker sent stat. Results by tomorrow AM.
CTA first to check flow. If it's an embolism, we cut. If we don't explore, what if the bowel dies? I'll call Director Han first. Just a heads up, this isn't our call.
Director Han, sorry, paging you this late. ER just took an acute abdomen. Case is a bit tricky. CT shows mesenteric vessel issues.
Labs don't confirm simple ischemia. Resident found autoimmune signs. Suspect, SLE.
Right.
Not a routine surgical case. Get the CTA now. Immune panel sent stat. Results by tomorrow AM. Got it. Please review tomorrow AM. All right. Dr. Han seeing him tomorrow. Run a CTA, keep vitals stable. If you're right, steroids will suppress it. Surgery won't fix this. But if you're wrong, by the time labs come back, the gut's dead.
Surgery is useless. If I'm wrong, we lose a bowel section. No SMA embolism. Lumen's patent.
Segmental bowel edema. Microvasculature's blurred. Conservative treatment tonight. Keep NPO start. Newtens ring per flow glues in awful pain. Keep a close eye. Call me if he shifts. Dr. Han's at 8 AM. Watch yourself.
True blood. State ABG and lactate.
Lactate 2.8. Bowels ischemic. ANAs positive. Titers 1640.
CTA rules out embolism. Lactic acids climbing. Bowels ischemic.
Bowel walls edematous.
Worsens and it's necrosis. Scope it out, then open. That's emergency surgery. You know the mortality.
I prefer exploration.
Scope it out first.
If necrotic, resect it. If not, close up. At least we'll know.
Director Han. Exam shows extra signs.
Go on.
Symmetrical PIP swelling in both hands. Faint red rash on the cheeks. Symmetrical. Butterfly pattern. Mottling on both legs. Joint pain for 6 months. Recurrent mouth ulcers. Hair loss worsening for a year. Rash worsens in the sun. CBC WBC 210.8. Plet 89. Urine protein plus. ANA positive. Titers 1640.
It's worse than I feared.
What does a positive ANA mean? Infections can trigger it too. So can meds. 1比640是高低度. Infection-related ANA is usually low. Plus, he meets over 6 SLE criteria. What about the ANA?
It's delayed. Lab says we gotta retest. Out by noon.
You want the ischemic bowel waiting till noon?
One more thing. If we treat for SLE, high-dose steroid pulse, methylprednisolone, right?
If bowel perforates on hormones, we can't feel it. By the time we spot it, it's septic shock.
Gives us over an hour. If no proof by 10, take him to OR.
Watch him closely.
Check lactate hourly. If lactate hit, regardless of results, straight to OR.
EHR 18 min left.
Dr. Wei.
Need emergency room consult.
Confirmed. Lab. Ortho. Rush dose C3 and C4. Patients Joe. Prioritize her results. We need them now.
Got it. I'll handle it.
If you're right, you save him. If you're wrong, I'll take the blame from Director Han.
Doctor, it hurts worse.
Didn't ER say surgery is likely? Then why the delay?
We're treating him. He's on fluids and painkillers.
So why is he still hurting? What's going on here? Why not operate? ER doc said surgery is needed. Then why wait to operate? He's hurting that bad.
Look, I'm sorry.
I know you're doing your best.
I'm worried, but I get it. Results will be back soon. We'll have a clear plan. We won't let him suffer.
Doesn't it hurt? C3 is back, 0.21. CIS is still running.
Lower limits 0.9. 0.21这么低。Got it, thanks. Criteria: ANA positive. Score over 10 means SLE. Arthritis 6 PTS. Butterfly rash 6 PTS. Hematologic 7 PTS. Renal 4 PTS. GC drops 3 points. Totals 26. Way over the 10 needed.
That's enough.
Under a quarter of normal. Critically low. Plus arthritis. Butterfly rash. Proteinuria. Double low counts. Complement 0.21. ANA 1.4 SCS. No need to wait for DNA tests.
That low?
Director Hun, compliments crashing. ANA theta plus multi-system signs.
I'm a surgeon, not a rheumatologist. I don't diagnose lupus. Rheum has to confirm it. Where's the team?
Almost here.
20 minutes out.
20 minutes later.
If room doesn't show or won't sign, I'll wheel them to the OR.
Dr. Lin.
Up to 3.4 from last night. Over 4. Ischemia means irreversible necrosis.
Dr. Lin.
Why did Chief leave? Didn't ER say surgery?
He's drenched in sweat from the pain.
When's the surgery?
Waiting on one lab value and a consult. If it's what we suspect, we can't operate. Surgery won't fix the ischemia. It could kill him.
No surgery? Will the pain just stop?
Are you unsure you can save him?
If it's a dead end, can we transfer him?
During transport, if his bowel ruptures, it's septic shock. I'm tracking his lactate. The OR doors are open. Give me 20 more minutes.
Dr. Lin Shu, general surgery.
Where's the consulting team?
Phone's team still isn't here.
They're en route.
Finished bed 27 dressing change. Skip other beds today.
Zhou Xuemei, which bed?
Right here.
Active systemic lupus is confirmed. Lupus mesenteric vasculitis. Diffuse inflammation in small vessels. Cutting it won't fix it. While immune cells attack the vessels, you resect this bowel and graft a new one. It'll still go ischemic. Start Wenji Solu Medrol pulse for 3 days straight. We'll manage the kidney fallout.
Hold surgery. Start the steroids.
Keep the OR ready. Keep anesthesia on standby. Keep monitoring lactate. If abdominal signs worsen, rush him to surgery, non-negotiable.
You tell him. We can only manage it with meds. Come in for checkups as needed.
Diagnosis is set.
It's lupus.
The immune system's gone rogue. Hit the gut blood vessels. That's why it hurt so bad. The facial rash, hair loss, and joint pain. All from the same root.
Dr. Lee, can it be cured?
Can't be cured. But it's controllable. Stick to the meds. Keep follow-ups. He won't face surgery risks. No midnight cold sweats from pain. Live your lives normally.
Just living normally is fine. Then let's control it.
Doc, itchy. Burning itch. Went to the clinic the other day. Doctor said the wound healed. Itch is normal while scars heal. Told me to use scar cream. I've been using it. No good. Itches all night. Can't sleep.
Deep inside.
Not a keloid.
Just hang on. Might hurt a little.
great after. These things plagued me for a week.
Incredible.
Doc, how'd you know?
It's a rejected stitch. Clean it up and you're set. No gadgets needed. Intuition's getting sharper.
Third time this year. 15 years practicing. Gallbladders, appendices, thousands of hernias. Pretty surgery means nothing. Need 2 core papers to get promoted. No rare cases, no cutting-edge data. How am I supposed to write?
What is it?
Zhou Xuemei's case file. Brought in ER, misdiagnosed. Till arterial catheter. Then immune markers. Complement levels crashed. Caught it in time. Managed conservatively. Full timeline. CT scans. Pre and post-med lactate curves. All filed chronologically. Mesenteric vasculitis from aortitis. Rare surgical immunology case. Almost went to the OR. Its rarity and reversal conditions meets all top-tier case report standards.
You organized all this?
Why not publish it yourself?
During Dr. Han's rounds, you took the heat to call that consult. You didn't give up on them.
Appreciate it, Lin Shu. Get to work. Bed 16 needs admission this afternoon.
Got it. I'm done for.
This is killing me.
The rotation exams in 3 weeks. Written and practicals. Pass rates under 65%.
Fail and you lose half your bonus. Plus you get delayed.
Even our residents are this cutthroat?
Surgery essay covers biliary variations. Only the chiefs know this. Who memorizes those twisted bioducts? I just wanted to do ortho. Now I'm memorizing sewer maps. I'm gonna lose it.
Temps normal. Drain outputs clear under 10 mil. Bowel sounds are back. Bed item meets discharge criteria. Clear them for discharge.
Ugh. I didn't drink. Got a few truckloads of frozen shrimp. Can't leave the stool unattended. Don't worry about me. Feed the kid and put him to bed. All right. I'll return after morning shipments.
Dr. Lin, can I head out? My car's been parked 3 days. Parking's costing me a fortune.
Hold on, let me check the incision. Any pain?
No pain. Feel refreshed. Back's a bit sore. That's normal. That mattress is too hard. Right shoulder blade's killing me.
You can't leave.
Why did the nurses say I'm cleared? Trying to charge me for another night?
It's not about the money. Something's leaking in your abdomen. Cancel bed 18's discharge. He's not leaving.
Are you kidding? I triple-checked the protocol.
Temps normal. Blood works clean.
Drains are all clear. That was a routine procedure. Why is he not leaving?
He hiccuped.
Diaphragm irritation and shoulder pain.
Hiccups and shoulder pain are red flags. Does ER paranoia work in surgery? No peritoneal irritation.
The omentum's walling off the leak. It's just the phrenic branch now. If he walks out now, the seal breaks in 12 hours. Bile floods his abdomen. He won't make it back.
Who said he's leaking?
Bed 18's nerves irritated. I suspect a hidden leak site. Stump leak or anatomical variance. I need the lab footage to confirm.
Follow me. See how perfectly my clips are placed?
Clear landmarks, no anomalies. Sutures flawless.
I watched it for 20 minutes, not a single drop. Where's the leak?
Rewind 30 seconds. Zoom in on the upper mid liver bed. Lateral aperture. Accessory bile duct.
You know it's under 1%? Severe leaks, less than 1,000. Just because he hiccuped, guessing a 1/100K chance?
Bile irritating the phrenic nerve explains his spasms and shoulder pain. If that aperture actually leaked, the fossa's already flooded. The moment he stands or moves too hard, omentum-bound bile floods the cavity.
Only ERCP can prove it. But it could trigger fatal pancreatitis. If there's no leak, he dies of pancreatitis. Lin Shu, you dare sign off on this?
I'm assigned to bed 18.
You can walk out! Dr. Lin ordered. If anything goes wrong, you're not liable.
Your dad signed for discharge.
You're on your own. Paperwork's filed. Who gave you the right to hold me? Drop the bag. Vials pooling in your gut. Heavy lifting will burst the sac. Don't try to scare me. Knew it.
Ding Nan. Hold the elevator. Page or 9. Anesthesia. Pre-intubation. Dr. Wei, I'll page them. Open the abdomen.
Roger.
BP's down to 85. EP's at 55. Septic shocks kicking in. Old week. Move it. Float liver with ice saline. Hand me dry gauze. Pressure with goals.
The 5-0 polypropylene holder.
固然 you take the sutures.
Suture lines clean, zero oozing. Flush abdomen with warm saline.
Lateral to fourth ventricle, clear.
But I saw no leak. It's leaking. If you hadn't cut that discharge, he'd be dead on that gurney.
That hiccup timing's too perfect. That's when I got suspicious. And your suture spacing's identical. The tissue's too fragile. I tear right through the fascia.
Tomorrow at 3 p.m., Gensur treatment room. Bring fresh pig skin. I'll teach you tension-relieving sutures. Tension-reducing suture. Big fat layer. Tense abdominal wall. Basic ER interrupted suture. Cuts skin in 12 hours. We'll split the incision. Watch the layers. Far. Near. Out. 1 centimeter from the edge at 90 degrees. No slanted grabs. Go straight through. Catch the deep fascia. Clear. Your turn. Stop. Fulcrum's off. Still forcing it. Angle it in. Out. Sharp eyes. Piece clues like radar. But off the mark. Sharp eyes won't hold the knife. Suture 200 more. Then you're ready for the OR.
Left accessory, right accessory duct. That's enough chaos. Why is there still an aberrant duct? 1 in 100,000. Attending docs might never see it. Testing on whoever gets it right. I'll call him dad. After gallbladder removal, if you're sloppy,
The stump leaks bile into the gut. One of the clearest signs. Bile irritates the diaphragm.
Hiccups and radiating right shoulder pain. Holy shit. How'd you memorize this obscure fact? Where'd you find the time?
Didn't memorize it. I pulled one out last night. What about tomorrow's exam?
Damn it. That silicone skin's too stiff. Tilt the forceps and the needle bends. Just tied the third knot. Time's up.
What's next on the circuit?
Last station, station 6.
Critical speed, thread the needle.
This year's SPs are super realistic.
Here's a trick to pass. Ditch the Sherlock Holmes stuff. They only know the script's answer. Go off track.
Examiners deduct points behind the glass.
It's a strict Q&A crossword. Stick to the script. Chest pain? Ask where it radiates. Abdominal pain? Ask about bowels. Never order obscure tests. That lab report doesn't exist. Just be a robot. Play it safe.
Next group. Candidate 014. Proceed to station 6. Candidate 015. Get ready.
It hurts. Like a knife twisting.
Sir, any history of heart disease? Where's your family?
weak under pressure, swayed by the patient.
Missed early shock signs.
Skipped vital signs first. 0 points. Lin Shu.
Call the number.
Let him in.
Candidate layer 15, head to station 6.
Stick to the routine. Don't overthink.
Hello. I'm Dr. Lin Shu. Where does it hurt most?
Bright red. Critical system warning. Irreversible collapse.
This isn't acting.
Doc, my back's splitting too.
Tearing pain in my back. BP spiking. Vessel's gonna burst. Aortic dissection. Follow the script. Stick to it. Pass. Stray, you fail.
Don't move. Stop acting.
Just breathe slow.
Chief Examiner. Hey, pause. End the exam. BP's crashing. Suspect type A dissection. Roll in the crash cart. Now.
Director Shen. Is he taking the role too far? Ring the bell to disqualify him.
Kill the countdown at station 6. Get the spare crash cart from the hall. Hurry.
Signs of aortic dissection rupture. Pulse is uneven in both arms.
Left pulse is barely there.
Right pulse is bounding. Cold sweat pouring down his brow. Pain shoots straight to his back. Tearing agony.
Not the scripted stabbing pain.
Check BP on the right arm.
Systolic 202. Diastolic 130.
Run downstairs for meds. No time.
I'm ripping apart. My back's splitting open.
Airways difficult.
Can't swallow it.
He's choking. Risk of aspiration.
Damn it.
Alert cardiothoracic. Prep the cath lab. Use the service elevator.
Stay with me.
Can't last 10 more minutes.
And my meds are wasted.
Suspect type A dissection. Systolic hit 220. Gave sublingual captopril. Dropping to 170 now.
CTA done.
No time. Skip to cath lab for angio. BP still spiking. She's in your hands.
How'd you know?
It's real. Cold sweat and neck veins show real spasm. Left hand tries to grab, right side moves more. Checks both radial pulses.
Pulse deficit severe.
Behind the one-way glass, I was gonna give you 0. You didn't verify ID. Ignored the exam protocol. Tore the patient's clothes. Crushed meds, forced them down his throat. Anyone's an instant fail. Rules guard against quacks. He swore the procedure's clean. But rules won't patch a rupture. I signed your report card. 0. This exam is void. I'll file a makeup request.
No need to delay. No penalty. I will draft the report.
Go back and wait. Next time, stick to protocol. Pills were ground too fine. Your technique was reckless. Even ER vets wouldn't try this.
Station 6 was chaos. Wheeled out on a cart. The sim patient freaked out.
He had a pre-existing condition. BP spiked, sent to cardio.
Holy shit, he's actually hurt.
Bad luck or good? Did you get a new scenario?
No.
Examiner scored me a 0. I broke protocol, but Dr. Shen will approve a makeup.
Makeup's fine. If he'd actually died, that'd be terrible. Let's go.
Back to the ward.
Uncle Wang, don't tense up. The incision is deep. Fat tissue is damaged. Tensions on the skin. It flips out on touch. Sutures won't hold.
Doc, stop pressing. It hurts.
Dingnan, I'll grab the heavy needle. Prep some IV tubing.
Sleeve the wrist at 90 degrees.
Ouch. No pain. Kid, what a precise grip.
Brilliant. Not in the standard curriculum. When did you learn that?
Just practiced on pig skin.
Lin Shu, done. Head to my office. Wei's looking for you.
The paper's accepted. I'm the corresponding author, your second author. With this core journal, you'll ace the final exam. I'll return the favor. I back what you did.
Thanks, Prof. Wei.
We had a quick meeting this afternoon. You crushed BP meds and force-fed the patient, rushing down with the crash cart. The whole hospital knows. Cardiac surgery asked me, do we have a monster in thoracic? Aortic dissection type A, missed the innominate artery by an inch. If you hadn't force-fed him captopril, it would have capped his BP spike. He wouldn't have survived till surgery.
But merit counts.
So does fault. The exam's recorded province-wide. You broke protocol, violating infection control. Your score stays 0.
Understood.
Though not yet. Director Shen cleared your retake. Director Han reassigned you. No more respiratory. Jian Sug's no match for your sharp eye. He wants to push you further. In ER and gen surgery, patients could point out the pain. Burp, cough a few times. But in ICU, intubated, sedated, and paralyzed, they won't talk or grimace at your exam. In there, your knack for reading faces, your exam intuition is useless. You face flesh, stripped of all feedback. It's a punishment and a test. Prove yourself. Don't get carried out.
Know how to tie a slip knot?
I can. Add a reverse stopper after.
ICUs don't cut. But daily central lines and peripheral IVs keep your hard-earned touch sharp. Don't let 2 weeks make you an ER doc. No matter how loud the monitors beep, remember, the patient in bed is still human.
You're a legend in the residency circuit. Flipped a table to save a guy. 0 on the exam, but your name beats a perfect score.
Morning.
Morning, Teacher Wei. The journal layout's set. It hits print next month.
Notify the academic office too.
You're locked in as second author. Dinner this weekend's on me. Just us. Just our team.
Deal. Thanks, Teacher Wei.
Pace yourself in the new depth.
Bro.
ER builds your rep. Jensuk holds the core. But where you're headed now, nobody cares if you're a genius. Survival's all that matters.
Teacher Luo.
I'm Lin Shu. I don't care how you spotted appendicitis, or how you stitched cuts like embroidery.
ICU needs no detectives, no tailors either. This place is a repair shop.
Once organs cross this door, just a blown engine.
In ER and surgery, we go by patient reports, pain or hiccups to gauge status.
But here, I've paralyzed them.
They can't cry out, no hiccups, won't complain.
Want to know if they're alive or dying?
Forget faces, watch the numbers.
Check CBI.
Lactate clearance, oxygenation index.
Grab a gown.
Bed 13's crashing.
His veins are flat. Central lines clotted off. BP's 55/35. Need a new right IJV line to push meds. Next is Puffy.
Probe just hits fat. Can't feel the carotid.
Blind stick on the IJV.
Dr. Lee, you've got 1 minute.
If you miss it, he dies right here. One minute.
Can't find landmarks, then switch.
I'll cut the vein.
Roger.
No air.
Blood's back.
Dark way.
Secured. All set.
Whenever I'm on duty here, for every blind stick catheter work, it's all on you. The lines you missed in Gensur, we've got plenty here. Let's see if your blind stick routine can keep that miss rate low in here.
Understood.
Why skip ultrasound guidance?
He's got severe subcutaneous edema. Ultrasound's just fluid and fast streaks. Can't spot the thyroid or the veins. With that swelling, imaging just throws off the needle angle. Felt the pulse instead, much safer.
At least you're sharp. Catheters in. Barely kept him alive.
But why the systemic swelling?
Got bloated, collapsed completely. Massive no-repeats propping up his BP. If the drip breaks for a sec, he's dead anyway.
Three hours. Pull his full med history, surgical history, sort out these labs.
Handover at 11 a.m. If all you do is blind stick and can't find the hidden trigger, dining hall's off limits today.
WBC's at 28.5. PCT's off the charts. Severe sepsis. Liver enzymes at 540. 24-hour urine's just 110 ml. Acute renal failure. Oxygenation index under 90. Acute respiratory distress. Heart failure, kidney failure, bone failure, late-stage diabetes. The last domino just fell. 10 diseases at once. No coincidence. A hidden cause started it. A week ago, surgery closed the spleen incision. No internal bleeding. Why the systemic infection on day 5? Fever started on day 4. They gave standard antibiotics.
10:30. Half an hour before your deadline. What's the catch in this mess?
Not in his chest, nor in the blood. Still a surgical issue.
He's got a leak.
He cut the pancreas. It's a solid organ. No leak. The drain's intact. Not a drop of GI fluid. So where's the leak?
It's a missed injury.
The crash didn't just shatter it. It caused a hidden contusion. Right at the pancreatic tail.
Where's the proof?
Drain sits right in the bed. Suction the exposed layer, masked from the naked eye. Jian Sug made a fatal error. Day 4, fluid turned cloudy.
mistook it for routine infection. Pumped in massive IV fluids.
This was the final blow. As long as that pinhole leak drips, pressers just sustain a dissolving corpse. Jansur Director Han, Bed 13's fever isn't routine. It's a missed impact injury. Your massive day 4 fluids pushed him into systemic shock.
Medicine runs on evidence. A leak would trigger peritoneal signs. Drain lacks pancreatic viscosity.
Drain suction the juice. Cloudiness is saponification. His vessels are leaking everywhere. Calm down. Let's open him.
Show me the labs. You diagnosing by eye now?
Director Han, it's Lin Shu. If drain amylase tops blood by 500x, that enough to operate.
5 minutes down there. I'm on my...
Amylase results.
Send it to the bedside machine. Rush it. Just drain amylase.
Alert anesthesia in the OR. Send down the full backup tray and cautery.
Push him upstairs.
His circulation's failing in the elevator and hall. Move him and he'll burst.
Don't move him. Roll the OR light in. Do it here. Bedside laparotomy.
Momentum's completely torn out.
Breathe in. BP is dropped to 70. Traction triggered a vagal reflex.
Uncle Lin. Double the neo push rate.
Necrosis at the pancreatic tail. Got a 2 mm tear. Focal patches around it.
Run. Press the deep retractor down 2 centimeters. Long clamps.
Push AD fast. Cardiac arrest. Charge to 200 joules. Ready. Clear the bed. Uncle Lee. Shock.
Again.
Move.
Steady.
Zhutao, it's up to you.
He's on max norepinephrine and dopamine. This heart's got 20 minutes max. Close up in 20 or he's gone.
Pro suture. 3-0. Yuanzhen. No bio patch. This thread won't hold. Keep stitching. It'll snap.
Massive bleed. He won't last a minute.
Grab the thinnest IV.
Snip the plastic sleeve. Thread it through both ends.
Use it for tension-free suturing.
Scissors. BDEV catheter. Push it through.
Flush abdomen with warm saline. Keep double tube suction. You're pressing too hard. Snapped free rib cartilages. Risk a flail chest later. But those presses saved him. Those 10 seconds finding the tear. His brain starved for oxygen. Left him a vegetable.
No flashy, impossible leaps. No clairvoyant powers. Behind these doors, every shard was clawed from the mud.
Found the exact cause. Pushes were brutal.
Stealing fluid without reporting. Broke the anti-infection rule. Go eat.
Hand copy the first 10 pages for the head nurse. ICU doesn't raise lone wolves. It only keeps machines that follow protocol.
Got it, Dr. Luo.
Holy shit. Pushio issued the correction notice.
Bed 13 missed a report.
Lin Shu. Here. Boss.
Add a bowl of beef noodles.
Extra meat. First day in ICU and you're pulling all the stops.
Compared to your cardiac arrest high-stakes game.
I was listening to rattling phlegm. It felt like a nursing home. But in ICU, no news is best news.
Plain broth noodles. No scallions.
That catheter tubing you snipped had burrs, Kennick microvessels. These are custom elastic shear guards for fragile suture sites. They're yours.
Got it. I'll keep them.
How'd this happen? He wanted oranges this morning.
All right.
I'm heading back.
Patient's crashing.
That 2D1 SPO2 just hit 50. He's turning blue. Rushing to ICU. I'll wait outside.
What happened?
Bed 21.
Zhou Rui. Just 23. Fresh grad today. Just a mild fever and a cough. Came in for a fracture.
He was complaining this morning. Just passed probation. Terrible timing. Boss won't hire him if he's out too long. Ask to bring his laptop to the bed.
Uncle Lee! Bring him back! He was chatting with me this morning.
O2 set at 45.
Heart rate 160.
His lungs are done. Air won't get in. Classic ARDS. Fastest decline I've ever seen.
Intubate.
Not water. Cement. Hyaline membranes on the alveoli. Lungs are solid lid.
Intubate.
Give sedatives.
Suppress the drive. I'll force them open.
Hook up the vent.
Be 5% oxygen.
PP 215.
Systolic at 60.
JVD is positive.
Tension pneumo.
Keep the rate low.
Stop forcing it.
Other lung will pop. Lungs gave out. Pumping air into stone. Get cardiothoracic.
Creep the ECMO. He won't make midnight.
Setups 50 grand.
15 grand a day.
Alert the family.
Bring cash and the DNR.
ASIMO's running. He's on bypass. When will his lungs clear up? Medicine can't predict it. Which means starting today, 15,000 a day, no limit. If we pull the vent, he dies instantly. Think it over.
We need to borrow.
We'll call tonight. Doctor, my kid texted yesterday about a bonus. He wanted to buy me a phone. He just started living.
Don't pull the tube.
Not a single day.
Contact medical affairs. Use the emergency fund. Buy him 3 days.
Uncle Lin.
The elderly in the ER.
I can accept that.
But he's 23. Just his first job. You caught rare vasculitis here. Can you tell if his lungs are salvageable?
Steroids. Anticoagulants. Anti-inflammatories. All paths blocked by this cement.
Can't tell.
Go finish that damn certification. Quit the Savior Act all day. Just sit here and stare at the screen. If your brain's clogged, in here, you're just dead weight. Get out!
Ouch. Ouch. Doc, stomach hurts. Hurts all night.
Lie flat, knees up.
No pain here.
No, doesn't hurt.
Pains in the lower right. Atypical peritoneal signs. Urgent blood work. Other than that, ultrasound suggests acute appendicitis.
IV cephalosporins now.
Dr. Shen, this student's unhinged. Diagnosis is correct, but his attitude's brutal. He's definitely failing.
Expect a doc who cracked 3 ribs in ICU. Obsessed with burning cash on life support. Show gentle empathy to a fake sick extra. At the passing line, send him back to the outpatient clinic. This room can't contain his burning rage.
Just give him a bare pass.
Procedure's incomplete. Without a proper reality check, this unbridled ego will wreck our ORs. Low score works. Let it be the cover. 6 months to hiring season. Top hospitals steal our best. We'll hide behind this 60. She's displayed in plain sight. Keep him locked to a hospital.
Got the spacers.
Here they are.
Hold the fascia back.
Crucial!
You squirm. One more time. I'll slice this leg off. Then drag you to director goo. Tweezers won't work. Tar and oil seeped into the muscle. It's solidified. We have to flush it out. Hold it down.
Gah! Cease. Easy now.
One more word and I'm amputating your leg. Who told you to ride that junk bike? Grit your teeth. Get your pants on. Use the fire exit. Pop antibiotics for a week. If I hear that bike within 10 kilometers again, next time I'm stitching you awake. Thanks. About today.
I owe you one.
Dr. Gu.
The asphalt flushing trick. Let me borrow that. Gotta get a lung wash in ICU. Jory's lung capillaries are shredded. If we pump in too much fluid, pressure will backflow into the veins. It'll blow his heart apart in seconds. We need a buffer zone. High concentration lavage shatters that crust.
Then we'll peel it off. Late shift giving you visions?
He's got severe ARDS.
Not a simple case.
His lung walls are paper thin. Flooding it with a liter of saline, pressure will crush his lung walls. It'll flood straight into his blood.
Before we pull it back,
His ravaged heart will just flatline. You're not washing his lungs. You're planting a water bomb in him, drowning him outright.
Normal hearts would flatline instantly. But he's different. He's on ECMO. The bypass machine is his backup heart outside his body.
As water hits his lungs, in that split second blood backs up, we can manually max out the ammo speed, taking over with its centrifugal force and sucking up the extra venous load.
Max RPM to counter the spike, suction to pull the sludge.
That cement-like crust sealing his lungs. We can tear a crack for air to get in.
In the ICU, simulations can beat the textbooks, but reality wins. The method you're suggesting, ethically, it's off-label use. No guidelines back it.
His father, in that ragged coat, is liquidating everything
Borrowed from the whole village
to buy ECMO time.
Sunk costs for this family are maxed out.
If we treat him normally,
And he doesn't make it. It's just fate. They'd accept it, even at a huge cost. They'd have to swallow it. He's losing both life and money.
But if you force a lung wash, even a split-second RPM glitch,
and he flatlines on the table, this off-guideline move becomes their outlet for despair.
In the families that need always eyes, you're not fighting to save him. You're running a rogue experiment. You will be crucified for murder, ruining your career.
Central venous returns crashing.
Push 200 milliliter colloid. Weaken the veins.
Sir, follow me. Sir, the 15K machine can't drain the blood. Don't wait till tomorrow. He'll be gone by this afternoon.
But Doc Lin found a way last night. A method to flush out the lung membrane.
It's a desperate gamble. If it works, he lives. If it fails, or if the fluid won't drain, he'll die on the table right then. Dies horribly.
so the chief won't put him on the table. He fears you'll lose both money and him. Sue him for murder.
Sir, I'm just a junior doc. I shouldn't tell you this, but I admitted him myself.
Sir,
do you dare gamble?
Page the pharmacy. Grab 50 vials of surfactant. Load them in the incubator. Heat it to 37.
Hook up the tubes. Open the dilution line.
You counting? I'm betting my career on this table.
You got 10. It won't flush. Let's quit medicine. Get out.
Flush the line.
Ready. 3, 2, 1.
Push.
Chest pressure clamps down like a vice, crushing Jory's main vein. If we don't fix it, Jory drops into shock in a minute.
Push it to max.
Keep the I'm holding it. It won't fail. Apply suction. Suction.
Airway pressure dropping. Nozzles shrinking. It's gonna blow. Hold just 1 sec.
He dies on this table.
If it breaks, I'll take the blame.
hold the meds. Tweak the drip, hold the baseline. But half-hour procedure. Don't log massive lung wash. Just write routine bedside suction. Family signed the waiver. But until he wakes up here, we're still on the edge.
RPMs are dropping. Pulled 200 ml of dead tissue. O2 sets back above 80. Didn't die on the table.
Thanks.
Dr. Lu. The engineer just left. The ECMO on bed 21 was overclocked, causing severe bearing wear. Manufacturer denies warranty. Reimbursement 108,000. You bypassed 50 units of surfactant. Unapproved for insurance or department funds.
Deficit, 45,000. Submit to medical affairs and finance. I'll hand it in personally.
It was an emergency. Overreach to save a life. Fines or suspension. I accept it.
郭培生。
This 150 is none of your business. Get back to work. He shouldn't take the blame. Hey, Director Shen. Dr. Luo faces audit and suspension.
Don't believe this. I spared you in the exam not to show off and break rule.
I won't. This benefits you. It's a win-win. This breakthrough ARDS rescue. Forms listed as 150K in losses. Repack it for the official report. It's top research to boost the hospital. I've got all the hemodynamic data. If you lead a hospital-level project, that 100K covers research funding.
Bring the raw data to my office. Keep it in mind. If the data falls short, I won't fund a dime.
Max out the equipment. Run high-dose infusions. Can your bonus cover the loss? You take the blame. The whole depth's bonus gets cut. If they die on the table, the family will flip this room.
Lao He, can I interrupt your rant? I reviewed yesterday's severe ARDS case. It's fascinating. Fills our ECLS research gap. Road sees funds through the hospital's research grant. It takes guts to lead a clinical trial. Uncle Lin filed these case studies properly. I'm stepping down.
Spin this violation into a research breakthrough. Let Shen Yue clean up this mess. Luo Feng couldn't pull that off.
Get out. The 50K is settled.
A sugar rush to wake Dr. Lu.
System alert. Shatter respiratory overload. Pulmonary fibrosis spells doom. Push past limits. Clear the trauma. We're past the crash point.
Drop that soaked gown. Grab a fresh one.
ER just wheeled one in. Dr. Wu cleared the tumor half an hour ago. Director Han made the cut. Not a drop lost. But in the elevator, patient went blue. Eyes rolled back. BP crashed to 0.
Suspect post-op bleed?
No bleeding at all.
Drain bags dry. Labs are back. All normal.
Hemodynamics are stable.
Han can't find the source. But he crashed out of nowhere.
Heart rate's 100. He's seconds from arrest.
That's Han's on gurney.
Guran's passing the buck. Grab your scope. Bed 3. Give me 30 seconds. Hook up the monitor! Hurry!
BP's bottoming out. No? Jamie D.
This can't be.
Impossible! I stitched 3 layers deep. Drains empty. Not a drop. Incisions clean. Why is he in shock? Why did he stop breathing on transport? Massive pulmonary embolism. Prep 50 milligram L2 plazis. Ready for IV push. Push lytics fast.
It's an
Not bleeding. 45 ml. Nowhere near a donation. Not a clot. A clot this big, it won't survive this. Not tamponade.
Hold the lytics. No fluids, no compressions. Massive air embolism. Deadly air stuck in his RV and valve.
Hear the mill wheel? If we compress or spike his HR, that air shatters to foam, clogging his capillaries forever.
Flat the bed. Han, help me turn him! Lock the bed wheels. Raise the stretcher foot.
Director Han, if not head down, arrow drop into the pulmonary artery, locked in the heart's dead space.
Grab a big syringe.
Through that leaking tube.
Lin Shu, drain that trapped air. Stay still.
That right IJ line, I placed it myself. After securing it, I tightened the lure lock myself. Missed the 4th click. The chief doc made a rookie mistake.
I owe you ICU a favor, or a life.
Next morning report.
I'll present the incident report.
Case study, massive venous air embolism. Hemodynamics case, ranked first. Foreign body case, ranked first.
Three days ago, CERT Team 5 resected a giant hemangioma. Elderly patient, deep tumor. 4-hour surgery. Blood loss under 50 mils. All reconstructions passed. But as they wheeled him out in the ICU corridor, he went into severe shock. Jugular veins distended. Heart nearly flatlined in 3. Cause this line, 35 RB air. Massive air embolism. It wasn't tightened. Air seeped through this half-meme gap.
It pierced the right ventricle like a bullet. It completely blocked the pulmonary valve.
I placed that tube before we cut the abdomen. This plastic cap was only half a turn loose. I screwed it on by hand before leaving.
That's how it was.
45毫升空气 of air, a half-millimeter blind spot. 30 years with a scalpel. Almost became a rigid, arrogant killer.
If Dr. Lin Shu hadn't calmly spotted the clot trap I insisted on, and forced the patient's head upside down under pressure to aspirate the bubble. Otherwise, this is just a death certificate for the family.
Fame seeking is done. Time to pay the debt.
The science step approved your 50K write-off.
But this money isn't free. Submit a high-capacity lung perfusion algorithm for the Provincial Health Committee by tomorrow.
I saw your grant in the group chat. I knew you'd hit the anterior lobe blind spot in the left ventricle. Pull off his head. It holds all the raw pressure parameters from the general surgery hyperthermic perfusion 2 years ago.
Thanks. With this data, that 150K bill is finally settled.
You bled all the air out for us. We're even.
Brought in 12 hours ago. No external trauma, no bleeding. Vitals are rock steady.
To spite her boyfriend, she sipped paraquat.
Arrived just in time. ER fast track fully open. 3 thorough stomach pumpings.
6 hours of hemoperfusion.
Plus full plasmapheresis. Tox lab results just came in. A textbook medical win. Paraquat cleared to safe levels. 0 signs of lung fibrosis.
Toxins are completely gone. Why hogging a bed?
Toxins are cleared, sure. Kidneys are safe now. But 3 hours ago, without a single warning, he plunged into a deep coma. Called neuro urgently. Bedside EEG is done. No hemorrhage, no tumors. But his brain waves are flat. Brainstem reflexes are gone. Neuro says severe tox-induced brain damage. Now he's in a stable vegetative state.
Brainstem reflex is gone. 0 muscle tone. I checked the full body CT myself. No major lesions. Not a cc of intracranial bleed. Paraquat's oxidative burn is irreversible. It didn't eat through his lungs. But free radicals breached the barrier. No point cracking his skull. Neurons chemically withered in the storm. He's in a deep coma. IV fluids only. Let him ride it out in ICU.
I'll go break the news to the family. We dialyzed his organs clean. All labs are green. But now we gotta tell them, he's just a breathing shell. Get your people ready. Once the family hears this, they'll tear the ER roof off tonight. I'm drowning. Verdict: Paraquat breached the blood-brain barrier, leaving neurons to wither. The system never calls this drowning. aggressive gastric lavage, AV diuretics and a dilute glucose drip. Poison's gone. But severe hyponatremia. Massive pure water flooded the gut. Plus ER's non-saline gastric flush. Blood turned to fresh water in hours. Osmotic pressure rules. Water rushed into the brain. Brain cells swelled up. Not poison gas burning the brain. Neurons drowned alive inside. Not burned by toxins. Patient-induced vomiting at home. Guzzled 5 liters of water at the ER to dilute the toxin fast.
Forced IVs of dilute glucose and diuretics.
Sodium hit 112. Severe occult hyponatremia. Massive water flooded the blood. Blood dangerously diluted, turning his veins into a fresh river. Water rushed down osmotic pressure, all flooded into the brain. He's not a vegetable. Brain's not dead. Under the skin, cells are swelling from fluid. High pressure swelling, no bleed, crushing brainstem neurons flat.
3 vets watched the paraquat chart.
Missed the sodium count. A primary cascade failure.
Prep 200 ml 3% saline.
Hold on. Don't push it through a regular line.
Swelling's gonna blow the pons.
Flush concentrated saline now, or wait for brain death.
If we go too fast, cells get ripped by osmotic shock. Dehydrate instantly, shrivel, snap. That's osmotic demyelination. Sweating's just a false coma. But myelin collapse is a kill shot. Even gods can't fix that. Load 50 milliliter into the fixed pump. Draw the 3% saline. Lock out the regular line. Current sodium's 1/12. Sodium can't jump over 8 in day 1. If it jumps past 8, his brainstem collapses. Set the hourly rate. 15 milliliters. Case closed. Brain swelling resolved. Gained internal med shard. New area unlocked. CNS injury shard. Keep this drip rate past the danger zone. Transfer to regular ward tomorrow PM.
Grab your paperwork. Go write your reports in the ward. Don't make a scene in here again.
If you need anything here, just give me a shout. I'll come be your extra arms.
Right.
Finally out. First term residency results are in. Damn. 72. Docked me for poor communication. Damn, I passed this part.
That's so unfair, though.
Do those examiners know real emergencies? They're ruining your national record.
Let's go. At least they're out. Report to the next department.